transport, for commuting. So because of that, the droplets inhalation is a very common mode of transmission of TB from one person to another. So if you are thinking that you are not having Mycobacterium TB inside you, you are wrong. You must be having it. It is just a matter of your immunity which is protecting you from developing the disease. Apart from that, ingestion is also self-swelling of infected sputum. Obviously, the pulmonary TB patients, there is a lot of mucus in cough. So many times people used to self-swallow it, which leads to uh, TB of GI tract. Then inoculation of organism into skin may occur rarely, very rarely, but it may happen from infected postmortem tissue also. This is also one of the less common, but is a mode of transmission. And then transplacental means that is the vertical transmission of tuberculosis from mother to fetus. So these are the possible modes. Inhalation is the most common. Okay. A little bit of physiology and structure and microbiology behind it. It is a gram-positive aerobic acid-fast bacilli. So we always check the A and B status of sputum in case of cough and fever to the patient. And because of the different structure, this mycobacterium is resistant to many disinfectants, detergent, and common antibiotics. That's why there is a separate group of antibiotics for treatment of TB. The problem with Mycobacterium TB is that they are capable of surviving and growing intracellularly, and hence it is very difficult to target them. Person to person spread by aerosol, that is inhalation droplet, is very common. Human are the only natural reservoir. Disease is most common in Southeast Asia, Sub-Saharan region, Eastern Europe. Basically, where there is overcrowding, disease is common. This is the microbiology part. Then again, in continuation to that, there is a peculiar feature of this mycobacterium that they resides inside the host in these four way, either as a rapid grower, so in the wall of cavitary lesion extracellularly, or as a slow grower intracellularly within the macrophages in inflamed sites, or spurters which show intermittent growth spurt, and the dormant stage, that is, do not grow for a long time, become active at only when the host resistance is low. That is what I am saying, that excuse me, almost all of us are harboring Mycobacterium TB in dormant stage. And you can see this line written in the last part of the slide, that bacilli continuously shift from one to other subpopulation. So in these four type of subpopulation, Mycobacterium TB resides, and hence it is very difficult to target it and eliminate it, because sometimes some of the Mycobacterium are intercellular, growing very slowly. If they are growing very slowly, they are less responsive to the treatment. Only the rapid growers are, which are extracellular, are very much sensitive to the drugs which we are giving. So here you can see the cell wall of Mycobacterium. The difference you can see and you can appreciate from other bacteria is that you can find this mycolic acid in the cell wall of Mycobacterium, and hence the name given to it. Bacterium having mycolic acid in the cell wall is called Mycobacterium. Apart from that, you can see arabinogalactan and peptidoglycan layer, and it is making it resistant to all the normal antibacterial drugs which you have read so far. So here, if we see the mechanism of action of first line drugs, which are HRZE. So here now we are starting our pharmacology part. So you can see that there are various layers like mycolic acid layer, arabinogalactan layer, peptidoglycan layer, and there is a as Karthik a girl. May I know, am I audible or not? Am I audible? Someone? Okay, Karthik. Okay. Fine. So, what part you missed? How much time I was inaudible? Have you seen? Have you understood this mechanism of action which I just discussing? I don't understand by the no. You have to write a little bit more so that I can understand because you are talking through the chatting, not you had just started it, sir. The starting of this slide before the mechanism. So this slide was okay. So just now I am audible, right? Okay. Okay. Fine. So thank you very much for letting me know. So what I was saying in this slide is very simple. That this slide is showing the mechanism of action of first line drug, which are H, that is isoniazid, R, that is rifampicin, Z, that is pyrazinamide, and E, that is ethambutol. Okay. So we'll discuss it further when we discuss the drug individually. You just need to understand this basic mechanism of action of all the first line drugs. That isoniazid is the drug which is inhibiting cell wall synthesis of Mycobacterium by inhibiting mycolic acid. Okay. Ethambutol is the drug which is inhibiting the cell wall synthesis of Mycobacterium by inhibiting the synthesis of arabinogalactose. Rifampicin is inhibiting RNA polymerase enzyme, which is RNA dependent RNA polymerase. Pyrazinamide is the drug which is inhibiting cell membrane and mitochondria of Mycobacterium, and Streptomycin being an aminoglycoside, it is a protein synthesis inhibitor, which you all know. So, what is the goal of chemotherapy in TB? The goals are that first thing is to kill the dividing bacilli, which is very, very important because the patient is, as soon as we target the rapidly growing bacteria outside the cell, the patient become non-contagious, which is the very, very important step because if patient is contagious, it will infect more patients, more persons. So the first thing is as soon as we start anti-tubercular therapy, that is what we say ATT, the patient becomes non-contagious because it is first targeting the rapidly growing extracellular mycobacterium. Okay, so this is our first goal to make the patient non-contagious. Second thing is to kill the persisting bacilli because now you made the patient non-contagious. Now the patient is no more transmitting the disease. This is half battle won. But now you need to treat that patient completely. There should be no persistent bacteria reside into it. Otherwise, it will become again, active, and the patient will become again contagious to the community. So, second goal is to effectively cure and prevent the relapse. And the most important nowadays is to prevent the emergence of resistance, because if the patient become resistant to all the drugs available, we call it XDR TB, and there will be no treatment left and nothing will left in our hands. So this is a very, very important goal to prevent emergence of the resistance. So whatever regimen nowadays we are giving to the patient is to accomplish these goals. First thing, to kill the dividing bacilli. Second thing, to kill the persisting bacilli. And third thing is to prevent the emergence of resistance. So here it is. The first line drugs are HRZE, that is isoniazid or ionide. This is written, spelling is wrong. It is isoniazid, then rifampicin, then ethambutol, pyrazinamide, and streptomycin. It was earlier the first line drug, but now we call it a reserve drug in first line. So first line are only HRZE. And you will see in the regimen also, I will discuss the regimen with you guys. What is the current regimen to treat TB? In that you will find only HRZE in initiation phase and HRE in continuation phase. Second line drugs to treat TB is written here. thiacetazone, para-aminosalicylic acid, ethionamide, cycloserine, Kanamycin, Amikacin, Capreomycin. The last three are aminoglycosides, which are container of streptomycin, which are used now apart from streptomycin. And the front four drugs we'll discuss. We will discuss in miscellaneous topic by Dr. Razzi. There are some new entry in second line drugs like fluoroquinolones, like ciprofloxacin, ofloxacin, levomoxy. This already been covered in your antibacterial topic. Macrolides, clarithromycin, azithromycin, rifabutin. So what is the difference between first line and second line drugs? The first line drugs are very, very efficacious, and we are counting on first line drug for treatment of TB. Once there is a resistance to first line drug, it is very, very hard to treat the patient with TB. Okay. So the first line drugs are highly efficacious and low toxicity as compared to second line drug. It doesn't mean that they do not have toxicity. Actually, ATT are known for their toxicity. There are a lot of side effects with ATT, and patient compliance is very, very less because of the side effects profile of first line drug. But as compared to second line drug, they are comparably less toxic, and hence we want a patient to continue the complete treatment with first line drug, and there will be no relapse, there will be no failure to the drug therapy, which will land up the patient to second line drug treatment. So HRZD is first line, aminoglycosides, macrolides, fluoroquinolones, sulfonamide like para-aminosalicylic acid, cycloserine, ethionamide. If you remember, cycloserine is this cell wall synthesis inhibitor, which you must have read in your discussion on cell wall synthesis inhibitor. Rifabutin is a congener of rifampicin. We choose it over rifampicin in certain conditions, which we'll discuss. So let's start the first drug, that is isoniazid. So there are many names to isoniazid, like isonicotinic acid, hydrazid. The short form is isoniazid. The short form is INH. It comes from isonicotinic acid hydrazide, and simply it can be denote as H in the regimens. First thing you must know that we are going to discuss here HRZE in this class, because this is the most important part of our discussion. Streptomycin being an aminoglycoside being already been discussed. So in HRZE, only E, that is ethambutol, is bacteriostatic, that is tuberculocidal. Tuberculostatic. Rest all are tuberculocidal. This one thing you must remember. So isoniazid is a tuberculocidal, that is bactericidal agent. So it is killing fast multiply organism, and it has good activity on slow acting organism as well, and they inhibit the growth of slow acting organism. Good thing about isoniazid is it acts both on intracellular as well as extracellular bacilli. So two of our initial goal were to first thing to make a patient non-contagious by killing the extracellular rapidly growing bacteria, which isoniazid is doing. Second thing is to eliminate the persistent bacilli inside the cell. So isoniazid is acting on that also, and isoniazid and rifampicin are two most important drugs in treatment of TB. And it is not active against any other microorganism. Means isoniazid is exclusively used for treatment of TB. There is no other use of isoniazid. Rest of the drug you will see many infections, to treat many infections, but isoniazid is an exclusively used for treatment of TB. Mechanism of action, as I already told, that it inhibits the synthesis of mycolic acid, which is a unique fatty acid component of Mycobacterium cell wall. So here is the mechanism of action of isoniazid. Being a prodrug, first thing you must know that isoniazid is a prodrug. So it enters within the cell, and then by using the enzyme catalase peroxidase, which is the enzyme of Mycobacterium. So if the cell is infected with Mycobacterium, then only isoniazid will act. Otherwise, it will not act. Because to become active, isoniazid is dependent on an enzyme, which is the enzyme of that particular bacteria, right? Without it, it will not get activated. That is why isoniazid is exclusively used in treatment of Mycobacterium, because in all other microorganism where there is no catalyst peroxidase, isoniazid will not get activated. So by using catalyst peroxidase of Mycobacterium, isoniazid get active. After get active, it goes to the cell wall part where it will inhibit the mycolic acid synthesis. How it will inhibit, we'll see. But this is the whole pharmacokinetic and pharmacodynamic behind isoniazid. So it enters basically by passive diffusion. It is a prodrug. It get activated by the enzyme catalyst peroxidase, which is a cat G gene dependent enzyme, okay, which is a bacterial enzyme. It means that if there is mutation in cat G gene, which is making synthesizing catalyst peroxidase, if there is mutation and this catalyst peroxidase enzyme will change its structure or something happens to it, it means that isoniazid will no more be remain active for that particular mycobacterium. So this is one of the reason for development of resistance to the isoniazid by CAT-G gene mutation in Mycobacterium. After getting converted to active form, it interacts with the mycobacterial NAD and NADP to produce dozen of adducts. And these adducts means clumps of NAD and NADP. These adducts, what it will do, NAD adduct will decrease the activity of a carrier protein, enoyl acyl carrier protein reductase, and another enzyme, beta ketoacyl carrier protein synthase. These two enzymes activity is reduced by NAD adducts, which ultimately lead to decrease the synthesis of fatty acid synthase 2, which is responsible for synthesis of mycolic acid. So earlier we just saw that mycolic acid inhibited synthesis inhibited by isoniazid. This is a single word answer to the mechanism action of isoniazid. How it happened? We saw that isoniazid being a product enters into the cell, get activated by catalyst peroxidase, and then interact with the mycobacterial NAD and inhibit mycolic acid synthesis. Now, how it is inhibiting mycolic acid synthesis? By producing the adducts, NAD and NADP adducts. And these NAD adducts are reducing the activity of few enzymes, which are responsible for synthesis of a very important building block of mycolic acid synthesis, that is fatty acid synthase 2. And it leads to the cell death. So this is the detailed mechanism of action of isoniazid. If I ask you one mark question that what is the mechanism of action of isoniazid, you will write it is a mycolic acid synthesis inhibitor, which is ultimately inhibiting the cell wall synthesis of mycobacterium. If I ask you 5 marks question on mechanism of action of isoniazid, you need to put the whole flow chart of how it enters, how it get activated, how it produces the adducts, and what that adduct will do. Now here you can see there are 3 genes. CAT-G is responsible for catalyst peroxidase. INHA is responsible for synthesis of enoyl acyl carrier protein reductase, and KASA is responsible for synthesis of this beta ketoacyl carrier. Means mutation in any of these 3, CAT-G gene mutation or INHA mutation or KASA mutation, will make Mycobacterium resistant to this resistant so far. Okay, so this is the detailed mechanism of action of isoniazid, and it is very important to read isoniazid thoroughly, because we need to C. Because isoniazid is exclusively used for TB, we must know everything about isoniazid. Okay. Okay, let's come back to the slide. Hmm. So apart from NAD there is a small, very small mechanism, that is NAD which inhibits the dihydrofolate reductase enzyme. This is a very minor mechanism. and it is more common in older patient and alcoholic. You just remember that out of all the four first line drugs, that is HRZE, ethambutol is more of a nephrotoxic kind of drug, means it attack more kidney, while rest of the three drugs, isoniazid, rifampicin, and pyrazinamide, they are more of a hepatotoxic kind of drug. Apart from that, rashes, fever, acne, and arthralgia can be seen. An overdose of isoniazid may be associated with the clinical triad of these three symptoms, that is seizure, which are refractory to the treatment with anti-epileptic drugs like phenytoin and barbiturates. Second is metabolic acidosis, and third is coma. So this triad of clinical symptoms, you must remember, can happen with isoniazid in case of overdose, or in case the patient is slow acetylator. Okay, seizure, acidosis, coma. So remember, seizure, acidosis, coma is the clinical triad of the symptom caused by overdosing of the isoniazid. There are some drug interaction like aluminum salts, which we used to give as antacids. It inhibits the absorption of isoniazide, so making it ineffective. So the antacids should not be taken 3 hours before and after giving isoniazide. Alcohol, obviously, drug increases the risk of hepatitis per se, and hence with any drug which causing hepatitis. Rifampicin is a microsomal enzyme inducer. You must know the list of drugs which are enzyme inducer and which are enzyme inhibitors. So rifampicin is an inducer drug, and which, because we are giving it along with isoniazid in treatment of ATT, it will induce the metabolism and will lead to the production of metabolites which are hepatotoxic. On the other hand, isoniazid itself is a microsomal enzyme inhibitor. So it will inhibit the metabolism of many drugs. And by inhibiting the metabolism, you all know the efficacy of drug will decrease. So we need to adjust the dose. So for example, paracetamol, phenytoin, carbamazepine, diazepam, theophylline, vincristine, warfarin, ethosuximide. These are the drugs whose metabolism will be inhibited by isoniazid, and it's required the dose adjustment. So normally isoniazid is a drug enzyme inhibitor, but it induces cytochrome P2E1, and hence all the drugs which are metabolized by this cytochrome 2E1, that is like fluorines, which you will read in your anesthesia part, it will decrease the effectiveness of those drugs. So these kind of drug interaction we should know. Now let's come to the second drug, rifampicin, a little bit about it. In next 5 minutes we'll close the session and we'll continue in next session. So let's see some pharmacology of rifampicin. So it is denoted by R in the regimen, and it is semi-synthetic derivative of rifamycin B from Streptomycin mediterranean. So it is the source of rifampicin is microorganism. There are many sources of drug like plant source, animal source. Here the source is microorganism. As I already told you, out of HRZE, only ethambutol is static, rest all cidal. So it is also, rifampicin is also a bactericidal drug. But it is not an exclusive drug for Mycobacterium TB like isoniazid. So it can be useful in other treatments like Staph aureus, Neisseria meningitis, Haemophilus influenzae, E. coli, Klebsiella, Pseudomonas, Proteus, Legionella. So you will find rifampicin in treatment regimen of many infections apart from TB. But as far as isoniazid is concerned, you will find isoniazid only in the treatment of TB. As you see that isoniazid is active against both rapidly growing extracellular as well as slowly growing intercellular bacteria. The rifampicin is better at on slowly and intermittently dividing bacilli on extracellular as well as intercellular organisms. That's why these two drugs, Isoniazid and rifampicin are basically the hero of the regimen ATT. These two are covering the whole spectrum: rapidly growing extracellular, slowly growing intracellular bacteria. Rest of the drugs we are adding actually to achieve the third goal, which is the prevention of the development of emergence of resistance to these two drugs. So there are a lot of resistance nowadays to rifampicin and isoniazid. To prevent that resistance, we are adding few more drugs to support rifampicin and isoniazid to cover the spectrum of mycobacterium. Apart from this, rifampicin can also be used in atypical mycobacterium infections like Mycobacterium, avium complex, MAC. You will see the regimen for that, and it is having very good resistance preventing action. So the addition of rifampicin to ATT is also to prevent the resistance to development of resistance to isoniazid. As I already told you, the mechanism of action of rifampicin is to inhibit the RNA polymerase enzyme, which is DNA dependent, responsible for DNA dependent RNA synthesis. So DNA to RNA and RNA to RNA, this conversion required some enzymes. This RNA polymerase enzyme is required for DNA dependent RNA synthesis of Mycobacterium. And by inhibiting this enzyme, the nucleic acid synthesis is inhibited and Mycobacterium can be killed. Okay. So TB patients usually do not get primary rifampicin resistance. Mostly you will see the resistance to rifampicin is after isoniazid only. And what is the mechanism of development of resistance? So like the gene which mutated in Mycobacterium developing resistance to isoniazid, there are some genes which are responsible for development of resistance to rifampicin, and this gene is repo-B gene. So by the mutation is repo-B gene, the beta subunit of RNA polymerase will change, and hence the target site will change on which the drug is acting, and hence the drug will remain no more, effective to that kind of mutated mycobacterium. Pharmacokinetic, all the drugs which we are giving in ATT are having very good bioavailability. That's why we are using it by oral route. So they absorb orally, well absorbed orally and widely distributed in the body. They penetrate, it penetrates cavities, gaseous mass, placenta, meninges like isoniazid. So as I said, rifampicin and isoniazid only are sufficient to target or to achieve our goal. But to prevent the development of resistance or emergence of resistance to these two most important drug of ATT, we are adding few more drugs like Pyrazinamide and Ethambutol. It is metabolized in liver, excreted mainly in bile, very less in urine. So nephrotoxicity is not at all a concern with rifampicin, but hepatotoxicity is. Any drug which is metabolized in liver is responsible for development of hepatitis or hepatotoxicity. A very, very important thing about rifampicin is that rifampicin increases the post-antibiotic effect of isoniazid. So, what is the advantage of combination of rifampicin with isoniazid? Number one, they cover a whole spectrum and which is important to achieve the goals. Rapid grower, slow grower, extracellular, intracellular. First thing. Second, third goal is to prevent the emergence of resistance, which rifampicin is doing actually. Rifampicin is also helpful in preventing development of resistance to isoniazid by mycobacterium. Also, it is increasing the efficacy of isoniazid. That is, the post-antibiotic effect of isoniazid is seen to increase by adding rifampicin. That's why this combination of HR is very, very, very important for treatment of tuberculosis. As I already told you, all the drugs except ethambutol, they are all causing hepatitis. Ethambutol is mainly causing nephrotoxicity. So rifampicin is also a hepatotoxic drug, but not that much as compared to isoniazid. It is less hepatotoxic, and it will lead to dose-related jaundice. So we again, like I discussed with Vivek that if there is lot of hepatotoxicity, we will continuously follow up our patient If it is intolerable, we will stop the drug and we'll choose another option from second line drug or third line drug. But our first goal is to check to see the efficacy. Second thing is the adverse effect. If it is tolerable, we'll continue the drug. If it is not tolerable to the patient, we'll change the drug. Then second is respiratory syndrome, like breathlessness, shock, and collapse can happen. Some dermatological conditions like purpura can happen. Some hemolysis, shock, and renal failure kind of thing can happen. This is very important. Cutaneous syndrome with rifampicin, flushing, pruritus, and rashes. It is very common, but very mild. So we can counsel the patient and continue the treatment with giving some dermatological preparation to treat these pruritus and rashes. But will not stop the drug rifampicin because of this side effect. Flu-like symptom is a known side effect of rifampicin. So you need to remember flu-like symptom with rifampicin. You need to remember hepatitis. You need to remember cutaneous syndromes. And a very, very important is the change of color of urine and other secretions, which may become red. It is totally harmless, and it is very, very important to counsel your patient before starting ATT, because once the patient's color of urine will change to red, they will feel like there is a blood in urine and they will stop taking drug or they will come to you. So it is a good counseling is very, very important, that it might happen. The color of urine and secretion might change to red color. There will be no problem at all. It is harmless and you should continue your medicine. This kind of counseling is very, very important to know. So patient should be told about this effect. You can see the picture here, normal urine which is yellowish and reddish, and it is very, very common. All those who are starting with ATT, within 1 week of treatment, starting treatment, the sweat, the urine become red, and there are a lot of red stain in the clothes. So patient counseling is very, very important about these harmless side effects. Interaction, as I already told you, rifampicin is an inducer, so it will induce the metabolism of many drugs, and by induction it will lead to failure of drug treatment, or there is dose adjustment will be required. And there are some examples written over here. Antiretroviral therapy zidovudin. Why it is written here? Because you will see, as I told you, we all are harboring Mycobacterium in our body. It is just a matter of our immunity. So the patient with HIV and other chronic disease, they are having immunodeficiency. In those patients, there is very, very common. TB is very, very common. So in HIV patient, TB is very, very common. So now for treatment of TB, you are giving ATT, which contains rifampicin. And for treatment of HIV, you are giving antiretroviral therapy, which contains some drugs like zidovudin. So you must note this interaction between zidovudin and rifampicin, that this microsomal enzyme induction property of rifampicin will make zidovudin less effective. So in that case, either we choose another ART which is not getting interacted by rifampicin, or we, replace rifampicin with rifabutin, which is having less interactions. Similarly with OCP, any patient having female patient reproductive age group taking ATT, you must counsel that patient to use different method of contraception other than OCP, because OCP failure is very, very common with rifampicin. There are two reasons. One is the induction. You can see here, it will induce the metabolism and lead to the therapeutic failure. And second is antihepatic metabolism. Rifampicin compete with OCP for this antihepatic metabolism, and again decreasing the efficacy of OCP. So it is your duty to counsel the patient to choose another method of contraception other than OCP, because we cannot afford a patient become pregnant while on ATT or having TB, because both the disease as well as the drug are not good for the baby. And apart from that, you can see warfarin, steroid, sulfonyl urease, digoxin, beta blockers, antifungal drugs like fluconazole, they interact with rifampicin. Rifampicin is not an exclusive drug for TB, which I already told you. Isoniazid is an exclusive drug. So rifampicin can be used in, you will find rifampicin in many treatment options. Like for a typical mycobacterium infection, you will see the dose regimen of rifampicin in MAC, that is Mycobacterium avium complex. In leprosy, you will see it as first line drug in MDT. In prophylaxis of meningococcal and Haemophilus meningitis, rifampicin is being used.